Hello. Today we're going to talk about CEREC inlays and onlays. My name is Scott Cairns. I coach dental professionals, and the reason I do this with PDS Health is to enhance the lives and the livelihoods of all the healthcare providers who choose to work with us so that they may best serve the patients, their patients, and themselves. So, really quick, I just want to go, why would we choose ceramic instead of a direct restoration? Quality is better with ceramic than it is with amalgam or composite. So amalgam breaks teeth. It's not technique sensitive, but patients don't want it. Composites leak. So the leakage is in direct relation to the placement technique. So the more technique steps and sensitive you are, the less leakage, but regardless, there's going to be micro leakage and it will fail because of that at some point in the future. Ceramic is technique sensitive, but the technique sensitivity is in the preparation. And then gold is a 2-appointment procedure, and it's cost prohibitive in some situations. So gold is a great quality, but we choose ceramic over gold primarily because it's a single appointment procedure. So another reason to choose ceramic instead of a direct restoration is that there will be fewer touches on a tooth. So every time we touch a tooth, we create problems downstream from our initial appointment or from that appointment. So this is going to delay more advanced dental procedures. And then once mastered, the use of ceramic restorations is very efficient of time. And there are delegatable steps with ceramic that even though you can delegate composite placement in Colorado, the technique sensitivity generally makes this not desirable for composite. So the first question is do you have the skills to help your patients with this? So most dentists only receive basic level of training with inlays and onlays in their dental school education because the dental school education is focused primarily on fillings first and then crowns. And if there's time, they'll fit these restorations into the curriculum. The learning curve is longer than composite, but once mastered, you can deliver a comparable comparable amount of time. So it doesn't become that much more time inclusive. The learning curve can be frustrating and it is challenging. So that kind of gets people not doing them. So what we're going to do is we're going to talk about, as you join us, committing to doing 25 Class 2 inlays. So again, you'll have a little chart and you can just mark them as you go. And the reason isn't to do 25 inlays. It's because after you've done 25 inlays, you have probably gotten past the technique sensitive portion of doing them, and you'll be more comfortable talking about them, and you can be more comfortable doing them in the future and helping your dental assistants learn how to do them better with you. So there is a decision tree for inlays, onlays, and crowns versus a direct composite. And so I just want to go over this really quick. Obviously, first thing you do is your data collection. So you're going to get your objective data as well as all your subjective data. And you're going to first determine, after you've looked at your objective data, is there a fracture in the tooth? If there is a visible fracture in the tooth, according to the American Academy of Endodontists in their position paper in 2022, that tooth needs to have cuspal coverage. Specifically in that paper, it was a crown. So that's just that kind of makes all the rest of the questions a non-issue. If they have a crack, then you're going to cover it up. If if they don't, then you go on and you ask the next question, which is, after you've removed everything, all the bad stuff in the tooth, the decay, is the gingival margin going to be in the proximal box, or is the gingival margin in the proximal box going to be in enamel? If the answer is yes, um, proceed to the next question. If the answer is no, then you can go on and just assume that it's going to be an indirect. The next question is the isthmus greater or less than half the intercuspal width? Again, if it's less than half, the answer is yes. You can consider it direct. You go on to the next question. If the answer is no, you go on to an indirect. The occlusion, is it tooth supported? Meaning, where is the occlusal contact going to lie? Is it going to be on the restoration or on the tooth? And then finally, you want to take into consideration whether or not this is a heavy function patient. Are there parafunctional habits, or does the person have really strong occlusion with big masseters, that kind of thing? Do they have any sleep issues, airway issues? So then we're going to, if they're all green, then you can think about doing a direct composite. If they're not, you want to definitely think about doing something that's going to be better, longer lasting, like an indirect restoration. So in order to determine whether or not it's going to be an inlay or an onlay, you want to evaluate the cusps and the support. If there are no cracks and the cusps are supported by dentin, then it's an inlay. If they have weak cusps, then it's an onlay or a crown. Okay, so then once you've determined what you're going to do, the next step is to try to help your patient understand the value of doing something that is better than something that is covered by their dental insurance company. So, not to diminish anything, but the saying is, you can lead a horse to water, but you can't make them drink. Our job is not to necessarily get them to make them drink, but it is definitely to lead them to making an informed decision for themselves. So it starts with awareness. They need to understand what has happened within their own frame of reference. They need to understand the consequences. If they don't do anything, is this tooth going to split? Is it going to rot? What's going to happen? What might happen in the future? You're going to tie it together, explain how the consequences relate to the values you've learned in the preclinical conversation. So this requires you to be an interpreter of the values that you know that they have expressed to you. So if they express that they care about their health, they care about longevity, they care about being more proactive than reactive, you tie that in, and then you ask them if they're concerned about this. Are they compelled to do something? If they are, that's when you talk about the different treatment options, whether that be a direct composite, an indirect inlay, an indirect onlay, or an indirect crown, or whatever the restoration may be.